Start with the basics. G-CSF stands for Granulocyte Colony-Stimulating Factor. It's a recombinant human myeloid growth factor used in supportive care for chemotherapy patients. The main purpose of G-CSF is to stimulate the production and activation of neutrophil precursors in the bone marrow. This helps prevent or shorten chemotherapy-induced neutropenia, a condition where white blood cells drop to dangerously low levels, increasing infection risk. By boosting neutrophil counts, G-CSF reduces the risk of febrile neutropenia, a potentially serious complication. The most commonly used agents are Filgrastim and Pegfilgrastim, along with several biosimilars. Let's see how these agents compare and why they matter in cancer care. There are several G-CSF agents available. Filgrastim, known by the brand name Neupogen, is a short-acting, non-pegylated form. Pegfilgrastim, or Neulasta, is a long-acting pegylated version. Biosimilars such as Zarxio, Fulphila, Udenyca, Xtenzo, and Nivepria offer similar effects at potentially lower costs. TBO Filgrastim Granix is another short-acting option, while Lenagrastim is used outside the US. Each agent has unique properties, but all share the goal of supporting white blood cell recovery during chemotherapy. Understanding these options helps tailor supportive care to each patient's needs. Comparing Filgrastim and Pegfilgrastim reveals important differences. Filgrastim has a short half-life of about 3.5 hours and requires daily subcutaneous injections until the patient's neutrophil count recovers, usually over 10 to 14 days. Pegfilgrastim, on the other hand, has a much longer half-life, ranging from 15 to 80 hours, thanks to its pegylation. It's administered as a single injection per chemotherapy cycle, often with the convenience of an on-body injector. This means fewer clinic visits and less hassle for patients. Both drugs are cleared from the body primarily through neutrophil-mediated mechanisms, but Pegfilgrastim's clearance is self-regulating, adjusting as neutrophil counts rise. CSF works by binding to specific receptors on myeloid progenitor cells in the bone marrow. This triggers the proliferation and differentiation of neutrophil precursors, accelerating the release of mature neutrophils into the bloodstream. The result? Enhanced immune defense during chemotherapy. Pegylation, the process of attaching polyethylene glycol to the molecule, extends the drug's half-life and allows for self-regulating clearance. As neutrophil counts increase, the drug is cleared more rapidly, reducing the risk of overstimulation. This mechanism is key to the effectiveness and safety of G-CSF therapy. Not every chemotherapy patient automatically receives G-CSF. Guidelines from ASCO, NCCN, and EORTC recommend primary prophylaxis based on the risk of febrile neutropenia, FN, associated with the chemotherapy regimen and patient-specific risk factors. High-risk regimens with FN incidence over 20% call for routine G-CSF use. Intermediate-risk regimens, 10-20%, may warrant G-CSF if additional risk factors are present, such as age over 65, prior neutropenia, or poor health status. Low-risk regimens, under 10%, generally don't require prophylaxis. Individual factors like recent surgery, infection, or poor nutrition can also influence the decision. Proper dosing and timing are critical for G-CSF safety and effectiveness. Filgrastim is typically given at 5 mcg/kg/day via subcutaneous injection, continued until the neutrophil count recovers. Pegfilgrastim is administered as a fixed 6 mg dose, once per chemotherapy cycle, either by prefilled syringe or on-body injector. Importantly, G-CSF should never be given within 24 hours before or after chemotherapy, as this can worsen myelosuppression. The on-body injector is applied on chemo day and delivers the dose about 27 hours later, eliminating the need for a return visit. Always confirm proper device function before the patient leaves the clinic. Core medications, G-CSF agents can cause side effects. The most common is bone or musculoskeletal pain, affecting up to 30% of patients due to increased bone marrow activity. Other common effects include injection site reactions, headache, fatigue, low-grade fever, and nausea. Rare but serious risks include splenic rupture, acute respiratory distress syndrome, severe allergic reactions, capillary leak syndrome, and sickle cell crisis. Patients should be counseled to report any severe pain, breathing difficulties, or allergic symptoms immediately. Bone pain can often be managed with acetaminophen, NSAIDs, or antihistamines, with opioids reserved for severe cases. Certain patients need extra caution with G-CSF. It's contraindicated in those with serious hypersensitivity to Filgrastim, Pegfilgrastim, or E. coli-derived proteins. Use caution in sickle cell disorders, pre-existing cardiac or pulmonary conditions, and avoid concurrent administration with chemotherapy. Lithium can increase neutrophil release, so counts should be monitored closely if used together. There are no major CYP450 interactions, as G-CSF is a protein-based biologic. Always monitor for fluid retention, allergic reactions, and signs of respiratory distress, especially in high-risk patients. Ongoing monitoring is essential during G-CSF therapy. Regular blood counts track neutrophil recovery and detect complications like thrombocytopenia. Patients should be educated on the purpose of G-CSF, proper injection timing, and device use. For on-body injectors, confirm adhesion and function. For self-injection, review technique and safe needle disposal. Advise patients to expect possible bone pain and to seek urgent care for fever, severe pain, or allergic reactions. Remind them to store medication properly and keep up with lab appointments, even if they feel well. Oncology pharmacists play a key role in ensuring safe, effective supportive care.